Alemozaffar is an assistant professor of urology at the Emory University School of Medicine. He received his undergraduate education from University of California, San Diego, with a BS in physiology and neuroscience, graduating summa cum laude and Phi Beta Kappa. He attended medical school at the University of California, Los Angeles as the Dean's Scholar and earned his MD in 2007 along with his election to the Alpha Omega Alpha Honor Society. Then he was followed by 5 years of urology residency training at the Harvard program in urology in Boston. And then he completed his urologic oncology fellowship combined with a master's degree in biomedical and clinical investigation at the University of Southern California. His primary clinical interest is urologic oncology. And Dr. Alemozaffar is involved in teaching and mentoring medical students and urology residents. In 2008, he was recognized for his teaching excellence by Tufts University School of Medicine. He is the recipient of multiple research awards and honors such as Best Video Abstract from the World Congress of Urology in 2010 and Best of Posters from the American Urologic Association in 2012. So please join me in welcoming Dr. Alemozaffar to June's Coding Development Program talk.
All right, thank you.
Yeah.
I think I talked loud enough. Never have been told I'm too quiet. So, well, thank you all. That's a lot of schooling, but at the end of the day, I guess it finally gets us somewhere, and here we are today. So, thank you for inviting me. When I first started here about 1.5 years, 2 years ago now, I worked pretty closely. While there's a lot of schooling and a lot of education that goes on, how do you take out a bladder? How do you do this? How do you do that? We never learn anything about how to bill for it or how to get any credit for it. We simply get zero education, absolutely none as a young physician. And so when I first started, I made it a point to reach out and really understand this process because it's something that was new to me despite all those years of school. It's amazing, actually, and it's something that I think is very important for the residents now, and I try to engage them in understanding that, look, at the end of the day, all the work you do means nothing unless it's assigned a code. So where does that bring us today? What I'm going to cover is urologic oncology. I'm happy to take questions at the end about general other issues that may come up, but really what I want to focus in on is talking about some of urologic oncology coding. So when we talk about urology, specifically in regards to cancer, we're usually talking about organ removal and sometimes some type of reconstruction. Now, that is for the kidney, anything within the urinary tract. Kidney, which makes the urine, the ureter, which takes the urine down to the bladder, which stores the urine, and in men, the prostate as well as the testicles are part of the genitourinary tract, which is what we deal with. And we're going to cover a variety of different procedures within each organ system and go over some of the codes with some of the common procedures. Real quickly, I want to just talk about the approach as well. There are multiple ways to take out an organ or do any other surgery for that matter. And classically, it's known as open surgery. And this is actually important from a coding perspective because, as you all know, there are differences in coding for laparoscopic versus open surgery. So open surgery is traditionally the operation that we're all familiar with. You make an incision, you cut, as you can see down here, and you expose the organs, and you use your hands and fingers and instruments and work through an open incision. Laparoscopic surgery specifically is small incisions that are made, and instruments are put through these small incisions to do all the work. So we're not making a huge incision across the patient, but we're working through these small channels, and that is laparoscopic surgery. Now, that has evolved over the last decade to include robotic surgery. Robotic surgery is laparoscopic surgery 100%. The only difference is that with the robotic surgery, as you can see down here, these are the same instruments, but they're controlled by this robotic arm. The robotic arm is then controlled by a surgeon who's sitting at a console. The surgeon has his hands in some instruments, and as he moves the hands, these elements move, and I'll go over some of the benefits of robotic surgery in a second, But I just want everyone to really understand that robotic surgery is just laparoscopic surgery using a special device known as the robot. And most cases are robot-assisted laparoscopic something. So almost all those codes should be laparoscopic codes in general if they exist. So if they don't exist and you're doing a robotic surgery, then we get into some questions about how do we code that appropriately, and I'll shed some light on that in a little bit. So what is robotic surgery? And the reason I'm speaking about this is I do a lot of robotic surgery. I still do a lot of open surgery, but robotic surgery is a little bit different. Well, what it is, it's these same instruments that I showed you on the previous slide, and what they have that's unique is a wrist. When you do laparoscopic surgery, what you're doing is essentially sticking a chopstick in and moving the chopsticks around. The robotic surgery, you stick a chopstick in, and it has wrists at the end of it that can maneuver and move instruments much more easily than just pure laparoscopic surgery. Other benefits of robotic surgery include that it's actually a three-dimensional field. So when you do a laparoscopic operation, it's like watching a television screen where everything is in 2 dimensions. Despite everything happening in 3 dimensions, all you see is a flat screen. And with the robot, there's actually 3 dimensions. When you are the surgeon and you sit down in this console and look through this special set of lenses, you actually see just like a 3D movie. So it's much more advantageous in being able to do complex surgery, especially deep in the pelvis. There's also magnification, about 10-fold. There's improved dexterity, like I said, with the ability to move your wrists. You can also have a second arm, or a third arm really, that's being used, and the surgeon controls it and is able to retract something and then work with the other 2 arms. And it is minimally invasive when compared to an open incision. Again, it's just laparoscopic surgery. So, that being said, let's move into some of the meat of the discussion. And what I want to go through is just some important distinctions that need to be made between what I find are commonly confused cases, because there are a lot of similarities, but yet they're entirely different cases. So, let's start with the kidney, like we said we were going to. One of the first things that is important to differentiate is the difference between what's called a simple and a radical surgery in general. A simple surgery never means that something's easy. Take it from me, surgery is never easy, okay? But what it does differentiate is that a simple surgery, like a simple nephrectomy, we're going to talk about a simple prostatectomy and other simple operations, what it's telling you is that it's not a cancer operation. It's an operation that's being done for some symptom or something where you're just trying to remove the organ, and you're less concerned about removing all the fat that's surrounding it that could be invaded by cancer or that sort of idea. So, for example, here we have a nephrectomy. Not all nephrectomies are the same. Nephrectomy, for those of you that don't know, is removal of the entire kidney. So one code is for what's called a simple nephrectomy. And there are some ideas here, just to orient everyone. This is a kidney here. This is all the fat and the adrenal gland and the fat that surrounds the kidney. And in a simple nephrectomy, you just come right inside the fat and just scoop this kidney out. Now, despite what it says here, and this actually brings me to another important point, this operation is not done for cancer. This comes straight out of the coding book, that special CPT 2016 coding book. There are multiple things in that book that I've seen that have really are not correct. Okay, so that's an important thing to note. While I know everyone looks at it as the Bible for coding and all that, you know, in reality there are issues with the coding book. And here's one simple one that I actually just noticed as I'm looking at this. This operation is never done for a simple nephrectomy. Don't do it. So what is a simple nephrectomy? If you ever see anyone that says, you know, the kidney was removed without gerotis, gerotis is the encapsulating layer of the kidney, without the perinephric fat, which is the fat surrounding the kidney, that's a simple nephrectomy. It can be done through an open incision, 50220. It could be done when it's complicated by prior surgery, but still in an open one, 50225. And I'll make all this available to everyone for afterwards, but this is hopefully just an explanation. Or it can be done laparoscopic, 50546. Now, a radical nephrectomy, on the other hand, is done for cancer usually. Sometimes it's done for other issues, patients who've had significant infections or other problems, but typically it's done for cancer. And what that involves, as we look down here, is it involves removal of the entire fat, perinephric fat, including Gerota's fascia, which is a fascia that encircles the fat as well as the kidney. Now, a point of contention is that oftentimes people think that that has to include the adrenal gland. It does not have to include the adrenal gland. There are plenty of times when we do a radical nephrectomy and we remove the entire kidney with all the surrounding fat and Gerota's fascia, but we don't need to take the adrenal gland because the tumor is way down here, the adrenal gland is way up here, and why would we take a patient's adrenal gland? So we will oftentimes say that it's a radical nephrectomy. I specifically dictate, mainly because I'm sort of interested in coding stuff, I will dictate adrenal-sparing radical nephrectomy. What you will oftentimes see, and I've heard of problems associated with other surgeons at other institutions, is I did a radical nephrectomy, but I didn't include the adrenal gland, and the coder said that it's a simple nephrectomy. Well, that's actually not true. And so it gets us to another point to where there's always something sort of, this is how we've always done it, this is how we should keep doing it, is not really the best way. So when it comes to a question like that, it's always important to really go back and see what the difference is. And if you actually read through this code for radical nephrectomy, it clearly states that it can be done with or without the adrenal gland, with or without the regional lymph nodes, which would be the lymph nodes surrounding the kidney itself, and I'm going to go into that for everyone in a little more detail, and with or without a vena cava thrombectomy. Okay, so another huge issue of discrepancy between what's actually done from a surgical standpoint and what's actually coded. So again, it's tremendously important for us to be able to properly code what we've done because the work is actually significantly different. I'm going to go through this in the next slide. Okay, but just note that that is what a radical nephrectomy is, whether it's done open, 50230, or laparoscopic, 50546. Okay? 50545, sorry. I'm going to skip just real quick to thrombectomy since I just touched on it, and I'm going to go back to the other one. So, we just said that removing the kidney, with or without the adrenal gland, part of the ureter, not the whole ureter, a different operation again, is a radical nephrectomy. Well, there are some patients that have tumor that creeps up in through the renal vein. This is normally where we cut the kidney, right here, up into the IVC, which is the main blood supply, the main channel of blood back to the heart, and they have a tumor in there. Well, this is a significantly more complicated operation. This is not a simple 50545. This is a significantly, that's a laparoscopic code, or a 50230 open, more complicated operation that requires us to dissect significant more amounts of tissue, find the left renal vein, clamp the left renal vein, dissect out the entire vena cava, clamp the bottom of the vena cava, clamp the top of the vena cava so that when we open this vena cava, blood's not squirting out from all over. So it's actually a significantly more involved operation. Oftentimes these tumors are going up underneath the liver, and so we're having to operate in a much deeper hole and with a lot greater blood loss and much more complexity. And usually what we have to do, as you can see has been done here, is we have to take a chunk of the vena cava out with this tumor and reconstruct this vena cava. Significant more amounts of surgery here. We're talking about sewing up the largest vein in the human body. Okay? So this is why oftentimes when we code a case as a radical nephrectomy with tumor thrombectomy in the vena cava, we will oftentimes have a separate code for reconstruction of the vena cava, if that's what we did, or sometimes there's tumor that's filled this thing so much that we cannot resect the whole thing, and we just cut the vena cava in half. And that's the ligation of the inferior vena cava. So be on the lookout for cases that, while they sound the same, radical nephrectomy, with or without vena cava thrombectomy. Okay, this operation, coming in and just taking this kidney, is much more difficult than when you take the vena cava than it is your standard nephrectomy. So, yes, while the code is there that says with or without vena cava thrombectomy, it's a tremendously different operation and requires extra codes to be added to really give credit to what work has been done. And oftentimes these cases will also have a modifier 22 because these are usually associated with huge tumors. You don't usually get a small tumor that has a tumor thrombus. You're talking about a major operation. So that takes us through the kidney a little bit, simple versus radical, and understanding some of the nuances, before getting caught into some coding rabbit holes, if you will. What other operations do we do on the kidney for cancer? We do partial nephrectomies. What a partial nephrectomy is, let's say a patient has a tumor in one part of the kidney, instead of taking the whole kidney, which would be a radical nephrectomy, we take a part of the kidney, which is a partial nephrectomy, okay? And what we do in a case like this is we measure out the tumor, find out where it is, we will clamp the blood supply, and then we will go ahead and make an incision around the kidney, cut this part of the kidney off, and then sew all the different things inside the kidney. This surgery is actually much more complicated than a radical nephrectomy because we're actually cutting across multiple major blood vessels, as opposed to in a radical nephrectomy, we take usually one or two artery and vein, and we're out and we're done. Significantly higher risk of complications. Urine leak can occur, blood loss can occur after the surgery because you're cutting through an organ. Anytime you cut through an organ, be prepared for more complications. So the code for an open partial nephrectomy, 50240, laparoscopic, 50543. Oftentimes, some of the additional codes you'll see is that we oftentimes use an ultrasound to measure out this tumor, 76998. And sometimes we take a biopsy of the base to make sure, hey, we got the whole tumor. So we'll take a biopsy of this base, send it to the pathologist to give us a frozen determination right there so that before we close up the patient, we know we've gotten the whole tumor. So these are some modifiers to look out for. So earlier I said a radical nephrectomy really just involves removal of the kidney and part of the ureter, as we saw here, part of the ureter. If patients have disease, sorry guys, I'm all over the place here. If patients have disease within the lining of the kidney, this is a very different situation and is very confusing for a lot of patients to understand. The kidney works to make urine. It's a urine-making factor. There's a funnel that captures all the urine, takes the urine all the way down to the bladder, and is stored in the bladder. That funnel is the ureter, and that funnel actually goes into the kidney a little bit. You can imagine you have the kidney here, and the funnel sort of goes into it to capture all the urine. Well, cancer can develop in the funnel, inside the kidney. It's not kidney cancer, okay? Cancer is named after the cell of origin from which it comes. The funnel is made of urothelial cells, which is the same thing that lines the bladder. It's the same thing. It's the storage mechanism. It's the same type of cells. So what patients can get is they can get urothelial lining of the ureter cancer inside the kidney. Patients always think, well, that's kidney cancer. It's not. It's not kidney cancer, and you can't treat it as such because it's a completely different biology. It acts completely differently than kidney cancer acts. So if there is a tumor within the lining of the ureter inside the kidney, there are a couple of treatment options, and I'm not going to go into all of them, but I wanted to go into one of the ones that is a little more difficult to code. One way we can treat it, and that's not on this slide, but just for the sake of being complete, one way we can treat it is we can stick a camera into the urethra go all the way up the funnel, go inside the kidney, and use a laser or something to zap it. That's ureteroscopic surgery. It's a whole different ball game than these big open operations. And that's fairly actually easy to code. There's a standard code, ureteroscopy, laser fulguration of a tumor. Pretty straightforward. Now, the one that becomes a little bit confusing is the major main operation when a tumor is too big to be able to zap with a laser, and it requires removal of the tumor. Now, you can't just remove the funnel, because then what's the kidney going to drain into? You oftentimes will need to remove the entire kidney and the funnel mechanism. So that's called a nephro-kidney ureterectomy. So you're removing the entire kidney, and this, I'm only putting this in here for picture purposes. You remove the whole kidney all the way down the ureter and a little piece of bladder, because you're trying to get rid of all the urothelium that could be potentially affected with this cancer. You never want to leave a piece of ureter that can then develop a cancer, and then you can never see again because it's up a little hole that no one looks into. So that's called a nephroureterectomy, and it is removal of the entire kidney like a radical nephrectomy, but with a complete ureter and a cuff of bladder. 1, 2, and 3. Now, this surgery can be done in a couple different ways. The nephrectomy, ureterectomy part can be done through one single big open incision, because you got to reach from all the way up to all the way down. That's 50234 through a single incision. If 2 incisions are made, which is pretty common, you do one incision for the kidney part of the ureter, and then you go down low and do another incision to do the bladder cuff part. Okay, that's through multiple incisions, 50236. Or you could do the surgery laparoscopically or robotically. It'll be the same code. Okay, 50548. Now, in addition, what some surgeons do is they like to do the bladder cuff part cystoscopically. For those of you that don't know what cystoscopy is, it's insertion of a camera through the urethra into the bladder, and some work can be done through that camera as well. There are little holes where you can put instruments in and do some work. So some physicians will do the bladder cuff cystoscopically. So they will do the nephrectomy and the ureterectomy through either one of these approaches, and then they will separately go in there and free up the ureteral orifice, which is where the ureter drains, and so that when they're doing this operation, they can just pluck that ureter off the bladder. So you've already made the circle, and now you can just plop it off. And if that's done, then you're talking about actually a different operation. 52214 is the code that best captures it. There is no specific code for resection of a ureteral orifice, but this is a code for resection of a trigone, which is essentially what you're talking about. So nephroureterectomy, kidney, ureter, and a cuff of bladder can be done in multiple different ways, in addition to being approached partly from a cystoscopic standpoint. And please feel free to stop me anytime along any of this talk if there's a question that's come up on a recent patient, or if you have a question in general. Okay. So that covers kidneys, really. Kind of covers some of the basic kidney stuff. Now, there's always going to be a lot more complexity than this, and when you see some of the operative notes from Dr. Master, maybe, or Ken Ogan or myself, sometimes you see us, multiple different procedures. This is kind of covering the basics of what we do on a daily basis. So that takes us to bladder. Okay, so we've covered the kidney, we've covered the lining of the kidney, and now we're going to the bladder itself. So what happens from a cancer perspective in the bladder? Well, patients get bladder cancer. It's called urothelial cancer because the lining of the bladder is urothelium. It's the same kind of cancer that develops in the ureter, same lining. And this cancer is really tackled in 2 different stages. Patients usually present with bladder cancer after developing blood in the urine, or multiple infections, or somehow they got a CT scan because they got in a car accident and they saw this mass in the bladder. The first thing that we always do for these patients is what's called a cystoscopy, which is when we insert a camera through the urethra and take a look around and see what we're dealing with. And before we really decide what we can do, we need to know exactly what we're dealing with. There actually are some other types of bladder cancers in addition to urothelial. I don't need to go into that because that gets a little sort of off base because the procedures are the same. But for us, it's important to know what's going on. And it's also important to know how deep the bladder cancer is involved. Just like you would think about skin cancer, the deeper something goes, the more layers that it involves, the more concerning it is and the more radical the operation needs to be. The first operation that we always do for a bladder cancer patient is what's called a TURBT, a transurethral resection of a bladder tumor. Now you guys may have seen this code TURP. Well, that's a transurethral resection of the prostate. TURs always just stand for transurethral resection of something. This is a BT, and there's an entire section in the coding book that covers cystoscopic procedures. So, how do we code for these? Based on the size. So, if a cancer is so small that it really only requires the smallest little biopsy, sometimes you'll see in the note it says a cold cup forceps or some kind of forceps was used to biopsy the bladder. Well, that's usually just a bladder biopsy, and that's 52204. Usually is for a very small lesion or a flat lesion that you don't need a big resection for. You can envision that. It's a little cup that comes out, biopsies it, and that's the biopsy. Now, I try my best to get the residents, when they dictate these cases, or myself, rarely when I dictate these cases, to put in the actual size of the tumor, because that's actually what determines the code. 52224, 34, 3540, depending on the size of the tumor. And it gets a little bit confusing, but if you look at, in general, Medicare-based coding systems, they just go based on the largest tumor. So if you have 10 tumors and they're 1 centimeter each, and there was one 2 centimeter tumor, you bill a 2 centimeter tumor. That's it. Other more private insurances, you can try and get away with billing, well, I did a 1 centimeter tumor here, a 1 centimeter tumor here, a 2 centimeter tumor here. Much more difficult to get away with. So in general, I think that what we do is just bill for the largest tumor. Some people use the aggregate volume of tumor that's resected. You can try that sometimes, but in general, it can be hard to pass through Medicare, but you can usually pass it through private payers. So a little tiny nuance there in terms of billing for multiple bladder tumors. And again, another note is that what we do after we resect these tumors is that there are cancer cells floating around, and we like to kill those cancer cells that are floating around because we've roughed up this tumor. We give a drug called mitomycin through the urethra, through a catheter, and it sits in the bladder for an hour to kill these free-floating cells. If we do that, believe it or not, in the operating room, when the patient is asleep, we can't bill for it. And the hospital gets charged extra for the mitomycin because it's considered all part of the same procedure. If it's done in the PACU, after the patient has exited the operating room, it's a separate procedure. So that is the standard of care, actually, is to do it outside the operating room. There is a little bit of reason behind that as well. You do want to wait the patient comes out, because when you do this procedure, the mitomycin, you have to clamp the catheter for an hour, put a catheter in, put the drug in, clamp it. So you don't really know if there's a problem if you do it right away in the operating room. You've just done your resection. Maybe there's a blood vessel that was in spasm. Now you put a catheter and you clamp it, and this actually just happened last week to one of the other physicians at St. Joseph's Hospital, and he had no idea that there was something going on until they unclamped the catheter an hour later in the PACU, and blood just came rushing out. They had to take the patient right back to the operating room. So there is a little bit of reason to wait until, okay, patient's out, patient's in the PACU, they're now awake. As a patient wakes up from surgery, there's actually a lot of coughing and pressure that they're generating that might pop a little blood vessel like that. So there is actually some reason to it as well. But that's just an important point to note when coding for mitomycin instillation after a transurethral resection of bladder tumor. Okay, that takes us to the best surgery, which is the cystectomy, which is removal of the entire bladder. It's actually an operation that consists of 3 different parts every time the surgery is done. It requires removal of the bladder itself. That's the cystectomy part. Other structures come out. In men, the prostate comes out always, unless they don't have a prostate, or if they've had some significant radiation to the prostate. But the prostate comes out when the bladder comes out. In women, usually the uterus, ovaries, as well as a strip of vagina, which is adherent to the bladder, comes out. That's step 1. Step 2 is the lymph node removal. Bladder cancer, as all other cancers, can spread to the lymph nodes, and lymph node dissection is a crucial part of bladder cancer surgery, which is why we see a lot of the codes are bundled. We're going to go over that in a moment. The last is urinary diversion. Great, you took the bladder out. How is the body going to get rid of urine? You have to somehow reconstruct the urinary tract. So anytime we talk about cystectomy, we're really talking about multiple different operations, usually some type of bundled operation. What is a radical cystectomy? As we said, it requires removal of the entire bladder, which sits right underneath your pubic bone, which is the bone that you feel right below your belly button. And what it includes is removal of the entire bladder. This is a man, so he has a prostate as well. And all of this would come out. In a man, you do bill separately for the prostate. If it's done open, 55840. If it's done laparoscopic, 55866. In females, you remove the uterus, 58150, 58571 if it's done laparoscopically. You do remove a part of the vagina, same code, either open or lap. No lap code exists, so you have to default to an open code. And you remove the urethra in the female because it's very, very short. So if you do a radical cystectomy alone, which hardly ever happens, you will bill a 51570. Again, it's a combination case that requires oftentimes some type of bundling. So we said step 1 was the cystectomy. Step 2 is the lymph node dissection. Now, this lymph node dissection I'm going to talk about also goes for the prostate, which we're going to get into in a little bit. Okay, so it covers both of those. It's the same codes. Why do we do a lymph node dissection? Because cancer will oftentimes go to the lymph nodes. It's one of the first places it goes. Cancer can spread via the blood, direct spread, or through the lymphatic system. If there's blood spread, then you're usually talking about more distant disease, and that's bad news. But if it's lymphatic, sometimes we can control it because we can control that area where the lymph nodes drain the main organ. So in pelvic surgery, we're talking about these lymph nodes down here. Now, just to orient everyone to this picture, this is a person standing straight up and down. This is their aorta. Their kidneys will be here and here. This is their vena cava, which we talked about already a little bit. This is their pelvis, pelvic bones, which you can feel right here. And the aorta comes down and splits off into, now this is a little basic anatomy lesson, but it is important because it actually does change how you build. The aorta comes down and splits off into the common iliac vessels and then the external and internal iliac vessel. And the same with the IVC, or the inferior vena cava. Comes down, splits off into the common, and then the internal and external. So, when somebody does a limited resection, and I'm going to go through this with you guys in a little bit more detail. A limited resection, what they're doing is they're plucking the vessels right around this area called the right obturator or the internal iliac artery. They're taking out the prostate or bladder, which would sit right here and here, and then they are plucking out these lymph nodes. That is what we call a limited sampling. It's a code that should hardly be used anymore because much evidence shows that a more proper lymph node dissection is beneficial for patients. So a limited sampling, these older codes, are used very sparingly. Now, some of the older physicians who do these limited lymph node dissections do get these codes. I'm not going to name names, but there are physicians out there that are still doing very limited lymph node dissections. So a pelvic lymph node dissection really includes anything within the pelvis. Makes sense. That would include the right and left external iliac lymph nodes. It includes this area where the pluck happens, the obturator lymph nodes. These are key words that you might see in a op note. The obturator as well as external iliac vessels were, lymph nodes were removed. That's a pelvic lymph node dissection. Now, there's some degree of confusion if removing the common iliac lymph nodes is a pelvic or an extrapelvic, but in general, I would include all of that as a pelvic lymph node dissection. Now, what I also do when I do these surgeries is I go a step further and I do a sampling of the periaortic and pericaval lymph nodes. Technically, anything within the right or left is considered pelvic. Once you get up into that middle part where there's no longer right or left, sometimes it's important for us to know if there's cancer there. If there's cancer here, this can still be considered regional disease. Regional disease. If there's cancer here, even though it's just one step above, it's considered metastatic, or M, when you do your staging. So that is an actual important point of distinction, which is why I and a lot of other surgeons do a para-aortic and paracaval sampling. It's not a true retroperitoneal lymph node dissection always. Okay, this is an important point, and I'm going to go to that in a second. So the codes that are used are 38571 if a laparoscopic pelvic lymph node dissection is performed, which includes external, common, and obturator lymph nodes. If a periaortic sampling is performed, that is actually 38572. It just goes, it's very little in terms of RVUs, but it just goes to credit that extra little bit of work. In an open case, a pelvic lymph node dissection is a 38770, and it's unilateral. So you actually have to use a modifier. Confusing, but that's how it is, okay? 38780 is a formal retroperitoneal lymph node dissection. This code is actually a little confusing, and a lot of stuff gets thrown under this code. But the true retroperitoneum is really extends up quite a ways. So using this code for an open dissection is a little iffy, in all honesty. This 38572 specifically includes periaortic lymph node sampling. This 38780 is a formal retroperitoneal lymph node dissection. So hard to include that one always when we do our open cases. You oftentimes just got to go with the pelvic lymph node unless the surgeon states a full separate retroperitoneal lymph node dissection was performed. Because we do that. We do that fairly routinely. We're going to go through that code in a little more detail, but this gives you a basic idea of why we do what we do and how to differentiate between pelvic and more formal resections. Any questions here? Okay. So, remember, bladder cancer requires cystectomy, step 1, requires lymph node dissection, step 2, and requires some form of urinary diversion, step 3. Again, oftentimes this is not done by itself. So these codes, while it's great that we have some, are very infrequently used, and they're actually not very specific. So if we look at urinary diversions, there are 3 major types that are currently used. In the coding book, you'll see some of the older types, which are diversions that we don't really do anymore, and that includes uretero-sigmoid ostomy, which is an old operation that hasn't been performed in a while, where you take the ureters, remember that's supposed to drain the kidneys, and you plug them in to the sigmoid, and then you poo and pee at the same time. So Not really done much anymore because of some concerns about infection, as well as some cancer concerns and things like that. A lot of those initial work were done in children who had bad bladder problems, and they had cancers that developed. Needless to say, it's not done much anymore. There are some people that are looking at the utility of it in an older patient population, where the work to do that is significantly less than the things I want to talk about now. So there are some people that are interested about doing that, but suffice it to say, not something we do very frequently anymore. The number one diversion that we do is what's known as an ileoconduit. Down here on the right, we take a segment of the bowel, cut it off, plug the bowel back together, use that little segment, and bring it up so that urine comes and leaks out a stoma. And that's known as an ileoconduit. By far the most common thing that's done here, and really nationwide. If you did that by itself, 50820, and it's a unilateral. So if it was the left, then it's unilateral code, you need a modifier for the right. The next type of diversion, which is probably the least frequently done, is what's known as a continent cutaneous diversion. Okay? Anytime you see some word that sounds a little bit much, just break it down. Okay, what does that really mean? Continent means that it's not leaking. It's cutaneous, it's going to the skin. So what this is a bladder that we make out of intestine. We take a little chimney and we plug it to the skin. How is it different than an ileoconduit? It's continent, which means that it doesn't just leak. You have to stick a catheter in to empty it. Okay? And some people find that beneficial, but in general, it's actually a significantly more complicated operation that has so many things that can go wrong. It's not a highly favored approach. The next approach is a neobladder. A neobladder is the same idea as here, okay, but instead of bringing it out to the skin, you bring it back to the native urethra. So the person urinates out their urethra like they did before. A little more complicated than your ileoconduit. You have to take a piece of intestine that's a circle. You have to open it up, fold it, sew it, fold it, sew it, fold it, sew it, so it looks like a ball. And you have to plug this thing back in. It can be kind of hard. But needless to say, it's a very good procedure that does have good outcomes, and we do perform maybe about 20% of our cystectomies get a neobladder. Okay? Funny to say, but look, same code. 50825. 50825. Completely different operation. Okay? So that brings us to the real meat of bladder cancer coding for cystectomy, which are the bundled codes. Again, if you did a cystectomy by itself, it would be 51570. Rarely done. You never just do a cystectomy and then leave the ureters to dangle. Okay? It doesn't really happen. 51575 combines that with the bilateral pelvic lymph node dissection because these surgeries are done hand in hand. Just as important as taking out the bladder as taking out the lymph nodes, and that's recognized. Moving on to the more common code, 51590, which is a cystectomy done with a conduit, open. And 51595, which is a cystectomy done with a conduit with bilateral pelvic lymph nodes, open. And the reason I emphasize open is that I do some robotic surgery, and there are no codes for laparoscopic cystectomy. So what do we have to do? We've met, I don't know how many times, DT, about this, and Donna and Mike and everyone, how do we build this thing that doesn't exist? We've tried the Z code path. That does not work. I've learned. We tried different combinations of these different codes to see really what fit. What we found that fit for us was actually using, for whatever parts of the surgery there are laparoscopic codes, taking that part out, billing that part laparoscopically, and then whatever's left, bundling. And so that's what we do now. So our robotic cystectomies, we bill with a 51590, and then one of those laparoscopic lymph node codes, usually 58572, because I typically do a periaortic lymph node sample. And that's how we bill the majority of our cystectomies. Now also don't forget, In a male, what else will we bill for? The prostate. Okay, perfect. So, bundle code. What we've been doing is 51590 with the laparoscopic code, and then plus or minus other additional stuff, which I'll get into. Next is the cystectomy neobladder. Again, terrible, terrible combo code, 51596. And what it really states, if you read it, is cystectomy performed with some type of continent diversion. And again, that could be the neobladder, the continent cutaneous thing, all sorts of stuff. It just gets hodgepodged into this same exact code. Now, I pointed this out to some of the people in this room. Lymph node dissection is not bundled in this procedure. It's actually not. It's not bundled. They never came out with the bundled code. This code, 51596, is just like the 51590. Does not include this additional part that makes this code 51595. So this is step one. Maybe at some point they'll come out with a code that bundles. They haven't yet. So cystectomy neobladder is 51596 with the separate laparoscopic lymph node code added on. Now, one other code that I still have not figured out, despite reading about it, Googling it, talking to other people who do this operation, talking to coders, talking to everyone else, is 51597. Very, very confusing code. If you read it, it is like you could have done anything to this patient, and it falls under 51597. You know, it doesn't appear that a lymph node dissection is included. What it really is trying to get at is patients who have a really bad pelvic cancer that requires removal of a bunch of their pelvic organs, and that's called the pelvic exoneration. The problem is it's not that simple. I mean, there's so many nuances. You don't take out half the time what you take out in one person that you will take out on the other. And so this idea of this code 51597 existing in a woman, for example, anytime you take out, if you read this thing, the bladder with or without the uterus, with or without the colon, with or without a colostomy, it's like it just is so dilute. It's almost to the point of, to me, being a very badly constructed code. I don't know if we use it. I'm sure we probably do on occasion. Yeah, but you know, I think that there are codes that are much more specific to what's being done, and this is one of those ones that's a work in progress where I'm still trying to figure out sort of, you know, how this falls into place. And oftentimes, if we do this kind of an operation, we're doing a two-surgeon team, and that's a whole nother ball game when you have a two-surgeon team. One person is doing the colon removal and the colostomy, another person is doing the bladder removal and the conduits. Do you put them together? Do a co-surgeon? Do you separate them out and have one do each individual thing? And that's something where I'm still trying to figure out what the best approach is. But needless to say, it's a very confusing code. So just if you're going to use it, be very mindful about it. It's not as a garbage can of a category as it seems. Okay, real quick about this. This is real boring. Partial cystectomy. I only put it in here to be complete. Again, it could be simple, which means that it's probably not for cancer. It could be complicated by prior surgery, or it could be, or it could require reimplantation. So, removal of the testes. Going over this real quick, just so everyone understands. Again, simple orchiectomy, not done for cancer. Usually, that's done through a scrotal incision. You just cut the scrotum, you pluck out the inside meat of the testicle, and then you close a little layer, the little sac back up. Simple. Partial, rather rare to do this actually, because cutting a part of the testicle is actually just anatomically doesn't work very well. But look, there's cases when we have to do it. A gentleman that I just did a month or two ago shows up with 2 testes masses, one on either testes. And I don't want to just go and cut both testes and make the guy impotent, so we try and spare part of the testicle on either side. Rather rare. The important part to note about any cancer operation done on the testicle is that it's actually done through an inguinal incision. Okay? Because if there is cancer here and you cut through it, you now violate the standard lymphatic channels that drain testes cancer. Now you completely ruin those freeways, and it's a no idea about where cancer is going to go. The benefit of testes cancer is that it has a very reliable pattern of spread. So always done through an inguinal incision, and that goes for radical orchiectomy, which is the standard operation for testes cancer, 54530. So where does testes cancer spread? So if testes cancer spreads, it spreads to the retroperitoneum. Remember, we just talked about the retroperitoneum. It's an area where we as urologists actually operate quite a bit. We're retroperitoneal surgeons. General surgeons are intraperitoneal. We're actually retroperitoneal. Kidneys are retroperitoneal. Blood vessels are retroperitoneal. All that stuff is retroperitoneal. So if testes cancer spreads, it spreads through the inguinal, underneath inguinal ligament and into the retroperitoneum. So if we do surgery for metastatic testicular cancer, we are essentially doing an intra-abdominal operation, but really it's behind and it's retroperitoneal. And the important distinction here is that oftentimes we're doing it for a mass. Now, these are some nuances which you don't need to know or really be involved in, but there are different stages where you can either have a mass or not have a mass in the retroperitoneum. If we go after a mass in the retroperitoneum, let's say that there is a 6-centimeter tumor sitting over the aorta, it's metastatic testes cancer, and we're going in there to do that. Well, that operation is not a retroperitoneal lymph node dissection. That is removal or resection of a retroperitoneal abdominal mass, and it's based on size. And that goes for any abdominal retroperitoneal mass. And those are the surgical oncology codes, which range from 59203 to 4 to 5, depending on the size. Now, in addition, let's say that this young man has a 6-centimeter tumor. Well, I'm not going to come and just take out this 6-centimeter tumor and call it a day. There's a chance that he has disease over here, down here, over here. And although, yes, I am removing a retroperitoneal mass, I will do a separate, distinct operation, which is a full, complete retroperitoneal lymph node dissection, which involves removal of all the other lymph nodes in the retroperitoneum, and that is billed as a 38780, which is that code I talked about a little bit earlier. Okay, so that code is usually done in addition to the resection of a mass. And the idea behind that is, look, you're not going to just want to bill for the mass by itself, or you're not going to want to bill a simple retroperitoneal lymph node dissection, because this is significantly more complicated. There are physicians that will go in there in a patient who has no mass and do a resection. The idea being he will develop it, okay, and I'm going to take it out earlier. That does happen, but you would bill at 38780 alone. So we're gonna race through prostate here because it's actually not too much, but I just really wanted to give you guys a couple of ideas about what prostate surgery involves. Again, a simple prostatectomy is done not for cancer. There's 2 different ways of doing it. It requires removal of the prostate, but it removes the inside core central zone of the prostate only. It actually does not remove the entire prostate with its capsule, which is a radical operation, right? When you are doing a cancer operation, you don't want to be inside the cancer. You want to be outside of the capsule or whatever it is you're taking, which is why the nephrectomy was the way it was. So with the simple operation, you're actually inside the prostate, removing prostate tissue. Now you can do that through a suprapubic approach, which means that you make an incision in the bladder to get to the prostate, or you can do it retropubic, which means you make an incision in the prostate to get to the central zone and scoop it out. Now, that's different from a radical prostatectomy, which requires removal of the entire prostate. One of the important things that you guys will oftentimes hear about with prostatectomy is that men can become impotent because the nerves that feed erections run right by the prostate, and you're trying not to injure those nerves. And in a radical operation, you're out here. In a simple, you're way inside here. Now, that can be done with a limited pelvic lymph node dissection, which is that limited little pluck we talked about. That's combined as 55842, or a full bilateral pelvic lymph node dissection, 55840, or the laparoscopic version, which is really the robotic version, 55866, no combined lymph node dissection. So that needs to be billed separately. And that would be those same codes that we've revisited a couple times. Now, in addition, something that I do is we actually sling the urethra right back here, back up to the pubic bone to help with the subsequent stress urinary incontinence that these men experience. That's a separate code, 51990. Nothing to stress about. I always make sure I dictate that separately. Almost done. A couple of common codes that you'll see smattered about that are just important to know exist. Exclusion of the small pelvis, small intestine from the pelvis with omentum or peritoneum. Anytime we do surgery in the retroperitoneum, we get worried about fistulas. Okay? We're taking stuff, we're cutting it, we're suturing it, we've taken other stuff, we've cut it, we've sutured it. If those suture lines meet up, a fistula can occur, and they will communicate. So we will often try to separate those two areas of the body out, and a common code that we use is 44700, which involves separation of the pelvis from the small intestine with either omentum or peritoneum. Enterolysis, you guys probably all have come across that code at some point, as well as ureterolysis is oftentimes done for some of our complex redo operations. I just did one yesterday where we had to plug in a new ureter on a patient who had a prior cystectomy neobladder who had a stricture, and this ureter was stuck. It took us about an hour just to free the ureter up. So we bill for ureterolysis. And then some other codes which I really don't want to get into. They're just too complicated and not that interesting. So just a big thank you to everyone, Hassan, Donna, Michael, Ramy, Chris, Deepti, and all the other coders who take our work and translate it into some type of code that we actually get credit for. Questions?
That was very informative.
Thank you. Great question. Great question. So they do serve a purpose. The general lymph nodes filter the lymphatic system. So they are little stop points along the lymphatic line that will filter these lymph node fluid. Now, lymphatics are actually contained within actual channels. If you're operating, and when we do robotic surgery, you can really see these little clear pipes that carry lymphatics up to lymph nodes and then continue to spread those up. They do serve a purpose. There are consequences to removing them. In general, the body is actually amazingly adept at healing and finding ways to get fluid back to where it needs to go. So for the most part, there's minimal consequences to removing those particular lymph nodes. You're not removing all the lymph nodes in the entire body, but when you remove those lymph nodes, the two biggest complications that you can get, leakage of lymphatic fluid into the abdominal cavity or whatever cavity that you have resected lymph nodes, because you cut a channel that then continues to leak fluid. So we have to be very careful about clipping or ligating big lymphatics. So you can get lymphatic collections, which are called lymphoceles, and that's a rather actually common side effect. The other side effect is the exact opposite. You clip this thing, it used to drain, and now it doesn't drain anymore. So what happens? Swelling. Swelling. Lymphedema. Good question. Yes? Is it more challenging? At first, yes. Later, no. The challenges to the robot are the initial learning curve of how to use any new tool. It's kind of clunky at first. You have to bring it in. You have to get it to work. There's extra things that you have to learn. But then once you actually get on the robot, the work is much easier. Because A, you're seated. B, your wrists move. So you can get at all these angles and areas which you couldn't get to otherwise. And so once you learn how to use it, it makes laparoscopic surgery significantly easier. But there is a learning curve. And during that learning curve, some physicians find it harder. Yes?
Do you actually have like little paddles or something for the robot?
Yeah, there are these little finger sticks that you put your fingers in, and you move your wrist, and it moves, and it's connected to like a hydraulic system that then feeds electronic signals over to the robot.
So
But you can pinch, and you can move, and it moves the wrist completely. It's actually a phenomenal piece of equipment. All right, thank you guys. We have CEUs for you guys. Yep, sure.